Welcome. In this session, we'll begin the discussion of three major pathways that traverse the spinal cord. That includes the corticospinal tract, the motor pathway, the dorsal column medial lemniscal pathway, a sensory pathway, and the spinal thalamic pathway, a sensory system. We'll deal with each of these separately, and we'll start out with the corticospinal tract, and then in subsequent sessions we'll deal with the other two tracts, and then in a final session we will combine all of these together so that you'll see where all three tracts are positioned relative to one another. We'll start off with overall objectives for this whole series of 4 sessions. And for this first, we will simply define the terms upper and lower motor neuron. We'll trace the trajectory of the corticospinal pathway to neuron chain. It's the simplest of the pathway and without any question the most important to most people. And then we'll list the characteristics of upper and lower motor neuron lesions. In subsequent sessions, separate from this, we'll talk about the other pathways, the dorsal column lemniscal pathway, and the spinal thalamic pathway. But for all of these, as indicated above, we want to identify the effective lesion at each point of the pathway as they travel along their trajectory, the spinal cord, brainstem, and cortex. And then in the long run, we'll want to be able to look at an image of a lesion and identify which pathway might be involved and predict the side and effect of that particular lesion. And then later on, we'll look at patients who have various complaints, signs and symptoms, and determine the possible location of a lesion that would explain those symptoms. But to begin with the corticospinal pathway. It is the major motor pathway responsible for driving and modulating the activity of motor neurons. It originates in the precentral gyrus and is responsible for refined, precise, voluntary movements. The corticospinal tract innervates motor neurons that will supply primarily flexor musculature of the distal extremities. Lesions, damage to this pathway, produce a weakness, sometimes called paresis, paralysis, of voluntary movement. Paresis just means a moderate weakness. Paralysis means a total weakness. It also produces, lesions to this pathway also produce spasticity, and that is a marked increase in tone of the muscles that are affected, and hyperactive reflexes in the affected regions. The corticospinal tract begins in the precentral gyrus in the cortex. And as represented here, different parts of the body are represented in different locations in the precentral gyrus. The hand most laterally, the arm a little bit more medial, the trunk near the crown, and the leg and thigh on the midline in the paracentral gyrus or paracentral lobule. And this separation will be maintained to some extent all the way down through the spinal cord. The pathway is a 2-neuron chain, an upper motor neuron and a lower motor neuron. The upper motor neuron is a pyramidal cell whose cell body is sitting in the precentral gyrus, also known as the primary motor cortex or Brodmann area 4. We can see that those neurons are going to send their axons down into white matter. This is all white matter down here once you see the axons, through the corona radiata to the internal capsule. The axons of these upper motor neurons will descend, and then they'll cross to the other side before they synapse on lower motor neurons in the ventral horn of the spinal cord at various spinal levels. These axons of the upper motor neurons descend through the internal capsule, seen here, into the midbrain, in the middle third of the crus cerebri of the midbrain. We see here, and it's reflected on the opposite side as well, just for description. They travel further into the pons and gather in the base of the pons, and from the pons travel into the base of the pyramid of the medulla at the most ventral portion of the medulla, forming the pyramids. At the bottom of the medulla, at the spino-medullary junction, they will cross over to the other side to occupy a position in the lateral funiculus, in the lateral corticospinal tract that we see represented in this figure, with arm fibers starting to peel off at the cervical level, trunk fibers peeling off at the thoracic level, and lumbar fibers peeling off in the lower cord for the legs, all in the lateral funiculus within the spinal cord. When the axons leave, here we see the spinal cord, when the axons leave the corticospinal tract to innervate lower motor neurons, they preferentially excite flexor motor neurons. That is, lower motor neurons that are going to flexor muscles. They simultaneously activate interneurons that are inhibitory to extensor motor neurons. These flexor motor neurons tend to be in the more ventral and lateral portion of the ventral horn. The axons will travel out through the ventral root to spinal nerves, and then on to peripheral nerves to their targets at the muscle targets at the neuromuscular junction. The blood supply to this pathway is shown in this slide, and you can see that there are multiple blood vessels that feed the corticospinal tract at various levels. And we'll start out at recognizing that in the midbrain, the posterior cerebral artery has penetrating vessels that feed the crus cerebri and the corticospinal tract within it. As we move down to the pons, we have a basilar artery at the midline, and penetrating vessels off of the basilar artery feed the corticospinal tract in the pons. In the medulla, we see that the anterior spinal artery, located at the midline, has penetrating vessels that feed the pyramids, as well as structures immediately above it, dorsal to the pyramids. As we move down into the spinal cord, we see that the anterior spinal artery also feeds the corticospinal tract within the spinal cord, and in fact feeds a large portion of the lateral and ventral portion of the spinal cord, including this corticospinal tract. We might recognize also that up in the cortex, the medial surface of the hemisphere is fed by the anterior cerebral artery, representing information from the foot and the leg, while the middle cerebral artery feeds the tissue representing the hand and the arm. A watershed area between the middle cerebral artery and the anterior cerebral artery supplies the trunk, seen right here. We see here the entire course of this corticospinal tract, starting in cerebral cortex, if it starts out on the left, in the precentral gyrus, the upper motor neuron cell body, in Brodmann area 4. It will send its axon down through the internal capsule into the midbrain, where it's in the crus cerebri. You see that over here. Down through the pons. You see it over here. Down to the medulla, where it is in a position known as the pyramids. You see that over here. And then at the bottom of the medulla, it will cross over to the other side, that is decussate, at the spinal medullary junction, or caudal medulla, to occupy a position in the lateral funiculus on the opposite side, until each neuron finds its target at a particular level, at which point it will activate a lower motor neuron. And the lower motor neuron is sitting in the ventral horn of the spinal cord, send its axons out through the ventral root to a neuromuscular junction at a muscle where it can cause contraction of the muscle. We see that represented here, that decussation at the caudal medulla, and continuation of the tract in the lateral funiculus, lateral spinothalamic tract. We'll now look at each level and recognize that at the cerebral cortex, we have, as indicated, the leg represented on the medial surface, the trunk and the arm more laterally, all in the precentral gyrus, and here in the paracentral lobule for the leg. And now we recognize that there's also representation of the head in the most lateral portion of the precentral gyrus. And those fibers that leave and are going to activate motor neurons in the brainstem are referred to as corticobulbar fibers. Bulb is an old term for the shape of the brainstem. And these will activate cranial nerve nuclei in the brainstem. They join up at the internal capsule, as we see here. And all of these that are in the left hemisphere, in the left cortex, will control the right head and body. And we see that pathway traveling in this location. As we move a little bit lower, we'll enter into the midbrain, and we see here the corticospinal tract is occupying the middle third of the crus cerebri, with the head represented most medially, the arms and lateral, and legs a little more laterally. As we said, fibers to the head muscles are termed corticobulbar fibers. Notice that the somatotopy is retained throughout this pathway. As we move a little bit lower in the midbrain, we now see represented the decussation of the cerebellar peduncles. The corticospinal tract is in the same position it's been before, in the middle third of the crus cerebri. And we see some of these other pathways. The medial lemniscus is located in this position. And of course, the substantia nigra is just above the corticospinal tract, represented right here. As we move into the pons, we see now the corticospinal tract interspersed among fibers coming from the cerebellum, but they stay in the basis portion of the pons. And we see also the fourth ventricle here, superior cerebellar peduncle, the middle cerebellar peduncle, and the medial lemniscus represented here. As we move lower to the medulla, we can see now that the corticospinal tract is compact in the pyramid at the base of the medulla, still on the same side that it originated. And we see that it is located just below the medial lemniscus and just below the inferior olivary nucleus. We can also see the solitary nucleus, the inferior cerebellar peduncle here, and the fourth ventricle. As we come down to the spinomedullary junction, at this level, we see now that the fibers in the pyramid are crossing over to the opposite side. This is the decussation of the corticospinal tract at the spinomedullary junction, or caudal medulla, moving from the pyramid over to occupy a position in the lateral portion. And we'll see that becomes the lateral funiculus. And at this level, we can see the synaptic relays that are coming up from the dorsal columns, and that is nucleus cuneatus and nucleus gracilis, the dorsal column nuclei, as they're spoken. As we come down to the spinal cord, now the fibers are on the opposite side of their origin, having originated on the opposite side. They're coming down in this lateral funiculus. And we see that some of those fibers will peel off at the appropriate level of the spinal cord to activate lower motor neurons. And the lower motor neurons in the ventral horn send their axons out the ventral root to a muscle, which they, at the neuromuscular junction, resulting in contraction of the muscle, primarily flexor muscles. Lesions to the corticospinal pathway should be looked at in terms of upper motor neuron lesions. Where the site of damage is, the upper motor neuron could be in the motor cortex, precentral gyrus, could be in the internal capsule, brainstem, or spinal cord. This is a long distance, could be 2 or 3 feet. So an upper motor neuron could affect anywhere from the cortex all the way down to the lumbar spine. That's all corticospinal pathway. A patient presentation with damage to that portion of the pathway, an upper motor neuron lesion, acutely is seen as spinal shock. In that setting, there's flaccid paralysis. It looks very much like a lower motor neuron lesion. Hypotonia. This is misspelled. It should be no P in there. It's hypotonia, reduced tone, and hyporeflexia. That is decreased or absent reflexes. And there may be literally no tone and no reflexes. Chronically, that is within days to weeks, we see spastic paralysis or paresis, different levels of weakness. That's the dramatic finding. And paralysis or paresis in this lesion is a difficulty in performing refined movements. There's hyperreflexia, exaggerated or increased deep tendon reflexes such as the knee jerk. There are contractures that may develop over time, and spasticity. Spasticity is associated with a marked increase in tone, and there's also this hyperreflexive state. This hypertonia is an increase in tone that develops over time. And also a Babinski sign in the foot. That's an upgoing toe elicited with a firm stroke of the sole of the foot from the heel to the toe. Plantar flexion, that is the toes going down, is a normal response. Although for children less than 1 year of age, it's normal to express a Babinski sign, that is an upgoing toe. But in an adult, an upgoing toe is a sign of damage to the corticospinal pathway, an upper motor neuron lesion. And then finally, you may see some level of disuse atrophy. That is, the muscles become smaller from lack of use, but it tends to be much milder than you see in a lower motor neuron lesion. This is what an upgoing toe looks like, elicited by the Babinski sign due to stimulation of the lower foot. And this is the appearance that you might see in somebody who has an upper motor neuron lesion in the cortex or the internal capsule, in which there is weakness of the face, arm, and leg. But you often in that setting will see a mild flexion of the arm and extension of the leg, and a drooping of the face, and loss of the nasolabial fold on the face when there is damage to the upper motor neuron, either in the cortex or the internal capsule, on the patient's right. All of these signs would be on the left. The geometry of the pathway dictates where the effect will be, so that spinal cord lesions, either inferior or caudal to the spinal medullary junction, produce an ipsilateral upper motor neuron sign below the level of the lesion. So spinal cord damage to the corticospinal tract produces symptoms ipsilateral to the lesion, below the level of lesion. And the location of the lesion, will, whether it's in the cervical or thoracic cord, will determine which part of the body is affected. So that if the corticospinal tract lesion is in the thoracic cord, then the arm is spared because it's controlled from the cortex, but it would produce ipsilateral upper motor neuron lesion signs in the leg. That is a spastic paralysis of the leg with increased tone over time. Above the spinal medullary junction, that is in the brainstem, the internal capsule, or the motor cortex, corticospinal, that is upper motor neuron signs and symptoms, will be contralateral to the location of the lesion. This demonstrates lesions to the corticospinal pathway and summarizes some of those effects. And that is damage at A or B, that is in the cerebral cortex or in the brainstem, produces a spastic paresis or paralysis contralateral and below the lesion. Damage in the spinal cord at C produces a weakness ipsilateral and below the lesion. Whereas damage to D, that is either at the cell body in the spinal cord at the lower motor neuron or in the peripheral nerve, will produce a will produce a flaccid paralysis, ipsilateral and at the level of the lesion. For lower motor neurons, the situation is quite different. If the site is at damage to the ventral horn motor neuron, as we've suggested, or at axons of the lower motor neuron in the ventral root of the peripheral nerve. For the cranial nerve, it could be the cranial nerve motor neurons, cell bodies, or their axons. The patient presentation is an acute flaccid paralysis with no activation of muscle fibers, hypotonia, and hyporeflexia. But you may also see fasciculations and fibrillations. Fibrillations are seen on the EMG. Fasciculations may be observable by eye. A fibrillation is an asynchronous firing of muscle fibers that is measured with an EMG, electromyogram, recording electrode in the muscle. It is caused by denervation hypersensitivity. That is, neurons synthesize new acetylcholine receptors and spread along the muscle fiber, and they become active asynchronously with degeneration of the presynaptic terminal of a motor end plate. You may also see fasciculations, and that's the behavioral manifestation, a clinical manifestation of the fibrillation that's recorded electrically. And they can be felt or observed as contractures, mild movements of the muscles below the skin in an uncoordinated way. These effects tend to subside over a period of days to weeks. Chronically, very similar appearance is observed. That is, a flaccid paralysis is observed, hypotonia, and hyporeflexia, as we've seen acutely. But also over time, very severe atrophy, denervation atrophy, because various trophic factors that come from the lower motor neuron that tend to enhance muscle metabolism and maintenance have been lost. Examples of this include poliomyelitis, which destroys the anterior horn cells, and Guillain-Barré syndrome, which is a demyelinating disease of the peripheral nervous system.